Recurrent diverticular bleeding. How do we manage as a gastroenterologist? So it happened when a patient had known history of diverticular disease of the colon and he even have history of diverticular bleed. We know that after every bleed, 10-30% may rebleed in future. So patients come in with parietal bleeding. When they have a history of diverticular bleeding, they roughly know this is another episode of diverticular bleeding. As a gastroenterologist, what goes through my mind? Number one, when the patient contacted me and say that, Dr. Y, I had a bleed 6 or 12 months ago, you did the scope to stop the bleeding, I have fresh blood again, I think I have another episode of recurrent diverticular bleeding. What do? Number one, in my mind, I think, can it be something else? Diverticular bleeding typically had no pain, no fever, no vomiting. They just bled. And the blood come out like watery diarrhea. They can be bright red, but often maroon, sometimes with clot. Usually they're not black color. Maroon, fresh blood with clot, no pain. In someone with history of diverticular bleeding, yes, very likely this is a recurrent diverticular bleed. The next question we ask is, do we need to admit the patient? Usually in our Singapore context, it is safer to admit to the hospital because hospital is readily available. It's usually within 15-20 minutes kind of distance from home, from most Singaporean home. We get admitted first. The next question that runs through my mind is, how stable or unstable is a patient? We check the pulse and heart rate and how they feel. If they feel dizzy, or they have a high blood pressure, or they have a high heart rate, or they have low blood pressure, or they have reduced urine output, we know this patient may be very dehydrated or may be hypovolemic, short of fluid. He may have bled too much. Then we need to, next step is to resuscitate. Give them fluid. If needed, give them blood. Main thing is to correct the low blood pressure, correct the fast heart rate, correct the symptom of lethargy. We check the blood count to compare with the O1. If the blood count drops too low in the Singapore context, if it is less than 8 grams per deciliter, normally blood bank will release blood. In hemoglobin of 9 or above, but they're actively pouring out blood from the bottom, we can call the blood bank and normally give blood as well. If the patient had hemoglobin of say more than 10, we don't normally need to transfuse blood. We don't want to deprive other patients of blood. We also don't want to over-transfuse the patient. The next question, what goes to the patient's medical problem? Often, people that present with diverticular bleeding, recurrent in particular, have multiple medical problems, such as heart problems, stroke, hypertension, diabetes, etc. Go to the problem, and very often, patients with diverticular bleeding have concurrent heart problems, so they are often on antiplatelet agent and anticoagulant. Discuss with the patient and the family regarding stopping the medicine. When they have active bleeding, it will be logical to stop antiplatelet agent or anticoagulants because they may make the bleeding harder to stop. But yet, when we stop them, we do have to warn the patient that bleeding, even though bleeding can be better controlled, they may have a risk of stroke or heart attack. So patient must accept that in order to, when we stop the blood thinner, it's easier to control the bleeding, yet they may have the adverse effect of a heart attack or stroke because we stop the blood thinner. If they can't accept that, we can keep them on the antiplatelet and the anticoagulant. It just makes life more difficult, tougher to stop the bleeding. Next question is, should we do a scope? If the bleeding stops by itself, that can occur in more than half the cases, we don't need to do a scope. Bleeding stop by itself. But if the bleeding continues, as evident by high heart rate, low blood pressure, continuing having blood of maroon color stools, then we need to do a scope. When to do a scope? When we prepare a patient for colonoscopy, we typically ask them to take no vegetable or fruit for 2-3 days, do the prep the night before. But for patients with diverticular bleeding, time is precious, time is money. We want to stop the bleeding and find the bleeding. So we will often do a quick bowel prep, ask them to take the bowel preparation, and we do the scope 5-6 hours later. If the patient is sick and unstable, it is safer to get an anesthetist. There will be an extra doctor, there will be extra cost, but it would reduce the risk of bad outcome. We do the scope. When we do the scope, it's often very difficult. Normally, when we put the scope in, we see nothing but blood and clot. But usually, if we are lucky and we did a lot of prayer before that, we can find a line of demarcation. If the colon is so long, they're bleeding from the middle, and the colon comes from left to right, when they bleed, the blood goes from this side. Usually, if there's time of bleeding, we see blood after this, and before this, no blood. So we do the scope, we see blood, suddenly we see a point of transition from a lot of blood clot to no blood. We know the bleeding source is somewhere here. We'll normally go to the end of the colon, come back to confirm that's the point, nothing else bleeding, no cancer, no polyp. When we come back, and then we'll sort of try to identify where's the blood. Often, patients with recurrent diverticular bleeding will have numerous diverticuli. I've seen more than 100 diverticuli. Every diverticuli may be a cause of the bleeding. We have to flush water, watch every single one slowly. If the diverticuli is actually bleeding, if we're lucky, we see active blood spurting out, then we say, bingo, that's the one. Inject with medicine, put a clip, stop the bleeding. If we are unlucky, the diverticuli is not actively bleeding at the time of the scope, then it will depend a lot on the endoscopist experience. For me, if we see feces inside the diverticuli, it's probably not bleeding. You see a blood clot inside, it may have just bled, so that may be the culprit, or it can also be not the bleeding one, but blood that was bled elsewhere, they happen to drop inside this divert. It's difficult to check. I normally flush away all the old blood and watch for a while and wait. If we see there's an adherent clot stuck at the diverticuli, this may be the cause of the bleeding. I will then inject medicine to stop the bleeding. If suitable, I'll put a clip as well to stop the bleeding. At the end of the scope, I will put the scope all the way one more time to make sure that no more blood. If you think they are bleeding from one particular diverticulum, you treated it, you wait for a while, you go to the scope back in, you see fresh blood again, then probably you have not found the right one. You have to look again, look for someone to bleed. If we found the right diverticuli, we stop the bleeding. Within about 5-10 minutes, we shouldn't see any more blood. We should all flush out. Another difficult question that we often see is that during a scope, we see a polyp. Should you take out the polyp or not? On one hand, taking out the polyp then can reduce the chance of cancer. On the other hand, if you don't take out the polyp, if you don't take out the polyp, it may become cancer. But if you take out the polyp, there's a 1% risk of post-protemin bleed that may confound the whole picture. So take a polyp or not, a difficult decision on the spot. And the next thing is, after the diverticuli, how confident are you? If you're confident, we can start feeding the patient and just watch. Blood is a laxative. If the bleeding is not stopped, over the next few hours, they will pour blood again. So if you have found the bleeding spot, you stop it, you wait for 5-10 minutes, no more fresh blood in the colon, you probably succeeded. And over the next 24 hours, if the patient does not pass any more blood issues, probably we succeeded, and that should be great. And that's the end of the story. So diverticuli bleeding, complex, the doctor's mind goes through many things. The most important thing for any patient is to look for the best hospital, look for the most senior endoscopist to do the scope to make all these difficult decisions. Recurrent diverticular bleeding, always a challenge.